Hi there folks, my name's Paul Davis. I'm one of the ITU consultants here at Frimley. I hate recording these shows probably as much as you hate listening to them. I've recorded this sort of once through already and it sounded awful. So I'm doing it again. It's going to be a bit sloppy. Don't worry too much about it. Get yourself a cup of tea and have a listen as we go through. You can come back to this presentation at any time. There will be some useful stuff towards the end that you may want to come back and re-refer to. There'll be some slides that we'll just kind of skip over because they're a bit wordy, but you can always come back and read them again in the end. So I've got a cup of tea in my hand. I suggest you do the same and we'll plow on through this presentation on haemodynamics. So the aims of what we're going to try and cover today during this presentation are how to assess a patient's haemodynamic status, how we can understand and interpret the monitoring we use on the ITU, how we can identify the cause of certain deficiencies within the cardiovascular system and then commence the right sort of treatment for it. And then we'll have a look at vasoactive drugs to get a very basic working knowledge of them. For the anaesthetists listening to this presentation, the stuff covered in this presentation will not be of sufficient depth for your anaesthetic exams and for the ICU exams for those of you who are keen on ITU. You will need to do further reading around the subject, particularly on the mechanisms of action of vasoactive drugs, their side effects and so forth. And you'll need a proper pharmacology book or exam revision book for that. This presentation will not be sufficient. The aim is to give you a working knowledge for the ITU at Frimley. So the aim of the heart is to pump blood to the tissue to deliver oxygen to peripheral tissues, okay? Delivered oxygen in the blood, or DO2, is proportional to a patient's cardiac output, their hemoglobin concentration, the oxygen saturations, and then there's a very small element of dissolved oxygen within the blood, which we can essentially ignore at normal pressures. So basically, if a patient's cardiac output drops, then delivered oxygen to the tissue drops as well, with the obvious after effects. The cardiovascular system also requires a pressure gradient across it between the arteries down to the capillaries in order to ensure that blood flows forward through the system. Without that pressure gradient, you won't get blood flow and you'll start getting something called stagnant hypoxia, which essentially is where the blood is stagnant within the system, it doesn't flow to the tissue, and you get hypoxia at the tissue. So if we're talking about mean arterial pressure, that is equal to cardiac output times systemic vascular resistance. As you can see here, cardiac output is a heart rate times a stroke volume. That makes complete sense. And that gives us the equation mean arterial pressure equals heart rate times stroke volume times systemic vascular resistance. That equation and the physiological principles that it implies basically give us the groundwork for the assessment and then the treatment of insufficiency within the cardiovascular system. If you're looking at a patient and they have a deranged map, you can identify which component or components that make up a mean arterial pressure require optimizing, and then you can apply a targeted treatment to improve that component. How you identify which component is deficient: simple stuff like history and examination can guide you, and then information from other sources, whether that's cardiac output monitoring or echocardiography, they all can inform you of which part of the system you need to optimize, and then they can help you to appropriately target your therapy. Okay, so assessing the cardiovascular system is no different in ITU than it is on any other hospital ward, except we've got some cooler equipment that can give us a bit more information. Your history and examination are no different to any cardiovascular examination you've done in your practice so far. The history may not be able to come from the patient themselves because they may be sedated, but you'll have to look through their medical notes and review what previous teams have discovered. Examination, you're looking for signs of cardiovascular insufficiency, so the standard examination findings will apply. You're looking at things like respiratory rate, urine output, peripheral perfusion and so forth. There's a list of things on the slide. that can give you an indication of a problem with the cardiovascular system. ECG obviously plays an important part, and you should look at serial ECGs if you're considering whether there is a dynamic change happening within the system, for example, evolving ischemia or a new arrhythmia. On to some of the equipment we've got here in the ITU. We've obviously got arterial lines in a lot of these patients. The arterial line will give you a trace on the monitor. We'll show you an example later, and that can tell you a lot about the character of the cardiovascular system. We've got cardiac output monitoring, which I'll go into in a little while. And we've also got a growing faculty of people on the unit that use echocardiography. And that gives you a great mechanism of assessing the cardiovascular system, as you can actually see the heart in motion, and that can tell you a huge amount of information about how well it is working or how badly it's working. It can also give you some really good information when you're considering a patient's volume status, and it's using lung ultrasound. You can also see if there's any evidence of left ventricular failure or pulmonary edema, or the absence of pulmonary edema where pulmonary edema or left ventricular failure was suspected. We're big fans of cardiac output monitoring on the ITU. It enables a better assessment of your cardiovascular dynamics, and it can show extra data such as cardiac output, cardiac index, stroke volume, and it can calculate and derive a patient's systemic vascular resistance. And this extra information can help us to specifically target therapy at the failing part of the system. It's important to remember that the information you get from cardiac output monitoring is not absolute, but it adds to the picture. So you need to build up a picture of what might be going on with a patient through history, examination, basic things like ECG, putting your hands on the patient to see whether they've got good peripheral perfusion or not, and then use the information and the trends of the data from the cardiac output monitoring to give you a picture of what's going on with a patient, and that will help you tease out the issues and be able to specifically target your treatment. The cardiac output monitoring we use in our ITU is LIDCO, which runs off a patient's arterial line. We'll go into LIDCO in a second. Other units in other hospitals may use something called PICO, which is a similar but different system. This presentation, I'm just going to talk about LIDCO. Again, for your examinations, for the anaesthetists, intensivists among you, you'll also need to know about PICO, but there's plenty of information you can find on the internet. And I suggest you do that. As I said, the system that we use in our ITU is called LIDCO. It's a lithium calibrated cardiac output monitoring system. It uses lithium in order to calibrate its waveform for it to correctly function. It's only validated in closed chest, fully ventilated, fully relaxed, i.e. paralyzed patients in sinus rhythm only. All the data for cardiac output monitoring essentially is only really accurate or very accurate in patients who are fully paralyzed on ventilators and in sinus rhythm. If patients are breathing themselves, if they're not ventilated, if they're in any arrhythmia, then the data cannot be said to be accurate. However, it still can be useful because you don't just look at absolutes, you look at trends and how those trends change over time. So yes, a patient might be in AF, but if they have an ischemic event at the same time as they're in AF, or their rhythm changes, you'll be able to see a change in their trends, and I'll show you the screen later where you can see that happening. You can see the change in trends in that patient, so you can actually see that actually this patient has got worse or got better and treat accordingly. The LIDCO can calibrate your cardiac output and cardiac index, your systemic vascular resistance and systemic vascular resistance index. The indexes are basically based on patient size and help relate that patient's cardiac output to that patient's size to help kind of balance things out a little bit. And calculate stroke volume, something called stroke volume variation and pulse pressure variation. That is the beat to beat or stroke to stroke change in volume coming out of that patient. And it will also calculate, if necessary, your delivered oxygen and your delivered oxygen index. As I said, it's important to look at trends as well as the current value so you can see what's been going on with your patient. The LIGCO is a good system, however it does require a good arterial line and calibration to be accurate. If you've got a suspect arterial line, the information it gives you won't be worth a damn. So bear that in mind when you're looking at patients, particularly patients who've come from theatre. A lot of patients we get from theatre have quite poorly placed arterial lines, and the information we get on the LIGCO can be compromised as a result of that. And the purpose of LIGCO, essentially it gives us some more data to help us assess response to fluid challenges, help us target inotropes, and things like that. Apologies for the poor picture, but this is the information you get on the LIGCO screen and how it is displayed to you. You can kind of have a look and you can see that it gives you cardiac output and cardiac index towards the top of the slide in the red. I've put some normal values just down the side of the slide so you can kind of see roughly what we should be getting for the patients. I've not put the units on there. The units are displayed on the screen, but those are sort of the normal values you should be getting from patients. So we've got cardiac output and cardiac index in the red there. Above that, the small blue writing, you can see the delivered oxygen there. The green numbers talk about systemic vascular resistance and systemic vascular resistance index. Below that, you see the MAP trend in black, and then below that, you've got stroke volume in mils and heart rate in beats per minute. You can see that the trends of this patient have changed over time. You'll get that sort of information when you're assessing your patients. And you can see there if cardiac output, for example, has dropped, if a patient has had an ECG change, or you can see if cardiac output has increased after you've instituted some treatment. Maybe you've started some dobutamine and you want to see if the cardiac output has improved, or you've started some noradrenaline and you want to see if the systemic vascular resistance has responded to that. So as you can see, the LIGCO can help us build up a good picture of this patient and use alongside examination and history. It can help us identify exactly what's going on with a particular patient with a fall in MAP or a hemodynamic insufficiency, and it can help us to guide our therapy. Now that's all very well and good. We can identify what's the problem, but unless we know how to treat it, what good is that to anybody? So we'll talk now about how we address the deficiencies within the cardiovascular system. So you have taken a good history, you've examined the patient, you've used cardiac output monitoring, maybe you or somebody else has echoed the patient, and you can see that there is a problem within one of those components of the mean arterial pressure equation, and you now need to fix that. So let's now discuss each component separately and how we can best go about optimizing it. The first thing we'll discuss is if you identify an issue with heart rate. Optimal heart rate is 60 to 90 beats per minute, and obviously a severe bradycardia or a severe tachyarrhythmia can adversely affect your mean arterial pressure and reduce your cardiac output. Most arrhythmias can be treated by a combination of physical maneuvers or with drugs or with electricity, and nothing I'm going to tell you over the next few slides should be new to you because it's all basically based on the ALS algorithms for bradycardia and tachycardia. It's important to know when we're considering the heart rate that the cardiac muscle, the myocardium, is perfused during diastole. And when heart rates increase, the element of contraction that changes is diastole. The time for diastole reduces. So as we increase heart rates, we get a reduced amount of diastolic time. You get a reduced period of time for the myocardium to be perfused. So effectively, if you push a heart rate too high, you're asking the heart muscle to do more work, but you're giving it less time to be supplied with oxygen. So that's why if you have a low blood pressure, you don't want to push a heart rate too high. You just want to correct a heart rate that's too low. An example I will give you is in cardiac surgery. We don't do cardiac surgery in our institution, but when patients have cardiac surgery, very often they have a pacemaker or a temporary pacemaker inserted. And that pacemaker is usually set sort of between 70 to 90 beats per minute. If those patients have a reduced cardiac output post-op, one of the things we can do is use the pacemaker to increase the heart rate to up to about 90 beats per minute. We wouldn't push the heart rate faster than that because you start to run into problems where you have myocardial oxygen insufficiency and you run into the risk of developing cardiac ischemia. So by all means correct a bradycardia to bring it into the optimal heart range, but it is not advisable to push a heart rate beyond, say, 90 beats per minute when you're trying to raise a MAP. Otherwise, you'll run the risk of the patient developing cardiac ischemia. So this slide essentially shows the adult bradycardia algorithm from ALS teaching. Essentially, we go through the ABCD approach for assessment and simultaneous resuscitation. You look for adverse features, whether they've got shock, syncope, or severe ischemia. And if the patient has any of those features, you then go down the yes side, looking at atropine, or atropine is the first instance. And if that fails to respond, then you go into the next box where you're repeating atropine, or you're using drugs like isoprenaline as an infusion or adrenaline as an infusion. If those drugs are not available to you or they are not working, we move on to transcutaneous pacing. Again, that's covered in ALS, and that uses a defibrillator with cutaneous pads for pacing. And if that fails, we're calling cardiology to arrange transvenous pacing. If you've got a bradycardia with no adverse features, then you look at what the rhythm is, and you're seeing if there's a risk of asystole with the patient's heart rhythm. So a standard sinus bradycardia shouldn't present any problems, but obviously, as you know, there are certain rhythms like heart block that run the risk of asystole, or the patient developing asystole, and will need to take protective measures for that patient, such as increasing the heart rate and involving cardiology. Some patients tend to run low heart rates, and if there's no hemodynamic compromise, then we just observe them. They may not need any therapy per se, but if they do then develop a low blood pressure or adverse features as indicated on the slide, then again go down the adverse features side of the algorithm and consider speeding up the heart rate. Alternative drugs to those indicated include things like dopamine or dobutamine. Beta blocker overdose or calcium channel blocker overdose can be treated with glucagon. And we also tend to use glycopyrrolate quite a lot in anaesthetics and intensive care as opposed to atropine. Glycopyrrolate takes a little longer to act, so it's not really your go-to emergency drug if you've got an acute decompensation, but it does have a slightly longer action, and its peak heart rate tends to be a little lower than atropine as well. It's a bit of a gentler, longer-lasting drug. Often used in theatre for anaesthesis if there's a bit of a bradycardia with a bit of hypotension. We just want to bring that up again, particularly after using propofol to induce somebody, or remifentanil if you're using TIVA. For tachycardia, again, this should not be new information to you. Again, this is from the Resus Council guidelines, the standard tachycardia algorithm. I'm not going to talk too much through this slide. You should all be familiar to you. You can always come back to this presentation, pause it, and have a good look at it yourself. Effectively, if a patient is unstable with adverse features and a tachycardia, you're going to use synchronized DC shock to try and cardiovert them out of that rhythm. And if that fails, then load with amiodarone. And if there are no adverse features, then you go down and you're looking to see if the QRS complex is broad or narrow, and then you're targeting your therapy thereafter. Amiodarone crops up quite a lot along this algorithm. It is domestos for arrhythmias. It kills all known arrhythmias fast. We do tend to use it a fair bit on the ITU with a 300 milligram loading dose over about 20 minutes. followed then by the 900 milligram over 24-hour infusion thereafter. Come back to this slide and have a look at it as much as you like, but we will move on for now. I did forget this slide, probable AF. This is our most common rhythm that we see on the ITU, patients who go into new onset AF. Very common with patients who are in sepsis. If you're going to treat AF, I would suggest you volume optimize the patients first, correct the electrolytes, specifically potassium and magnesium. I tend to push the magnesium over 1 and push the potassium over 4.5. And then if that doesn't correct the AF, the arrhythmia, then go on to using either a drug like digoxin, metoprolol, bisoprolol, diltiazem, or amiodarone. But it always pays to correct volume status and electrolytes first before starting your treatment, because very often that is enough to push patients who have drifted into AF back into normal sinus rhythm. Now we will talk about patients who have low stroke volumes, and I've finished my tea, which is sad but appropriate because we're now going to talk about hypovolemia and how best to address that. Low stroke volume is usually caused by either insufficient left ventricular preload or reduced left ventricular contractility. So essentially preload would be a volume issue, and then contractility, you're looking at a myocardial failure issue. Examination and cardiac output monitoring can give you a good indication as to which is most likely. Echocardiography in this case is a fantastic device, tool you can use. You can actually get good images of the myocardium, and you can see if it's functioning well, if it's well filled or not, and that can indicate which is the most likely cause. Reduced contractility, so myocardial failure, that generally requires inotropes to treat, but a reduced LV preload can be caused by either RV failure, so there is plenty of volume on board but the right ventricle isn't contracting, that's bad, or it can be caused by hypovolemia, and that's not so bad because that's usually pretty correctable. If we just think about our Frank-Starling relationship and when we talk about stroke volume, obviously the graph indicates here that as you increase your ventricular end diastolic volume, you stretch the cardiac muscle fibers to the point of optimal contraction, so you get the best contraction of the myocardium and the optimal stroke volume. If you overdistend the muscle fibers, you start to get failure of the myocardium. If you think, for example, dilated cardiomyopathy, where you've got very, very distended, poorly contracted fibers. But volume overload can push patients into left ventricular failure, for example, and they then need drying out to try and correct that. This graph will show the effects of inotropy as well. So if you start patients on inotrope, for example, dobutamine, or something like digoxin, you can get increased cardiac contraction, and we'll go into later on how those drugs work. And there you get a bigger bang for your buck. So for the same left ventricular end diastolic volume, you get a greater stroke volume because the heart muscle is working harder. And also you can get a negative inotropic effect if you use drugs like beta blockers, where again for the same left ventricular end diastolic volume you actually get a weaker contraction. Okay. If you're giving patients a fluid challenge, what you're trying to do is move people from the left-hand side of that graph further towards the center to effectively try and get them towards the top of that curve, and before the patient starts falling away, before you start falling away too far to the right. When you give people a fluid challenge, you're essentially increasing the left ventricular end diastolic volume and assessing to see if that patient responds positively to that. So how do we know to give fluid? Well, so we talked about the swing on the arterial line. You can see here, this is a basic art line and ECG trace, and you can see at the bottom there the the green lines indicating that the patient being ventilated with an in-breath and an out-breath. You can see that the difference between the peak arterial value and the trough arterial value shows a big swing on that arterial line, and that effectively means that the patient's cardiac output, the patient's stroke volume, is being influenced by the change in intrathoracic pressure as they're ventilated. As the pressure inside the chest increases during positive pressure ventilation, you get reduced venous return, so you get reduced output from the right ventricle into the left ventricle and a lower left ventricular stroke volume. And then as you release that pressure in the chest, the intrathoracic pressure decreases, you get increased venous return to the right side of the heart, you get better forward flow, and you get an increase in your left ventricular output, and you get a higher stroke volume. So if a patient has got a big swing on that art line, then that shows they've got a big pulse pressure variation or a big stroke volume variation, and that can indicate that the patient would benefit from a fluid challenge. So let's briefly talk about how we give a fluid challenge on the ITU. Well, we assess a patient and assess that there is a likely requirement for fluid, and we've just been through that. And then we administer a bolus of fluid. Now, a bolus of fluid would either be 250 or 500 mils, depending on how brave you are feeling or how empty you think that patient is. It's to be administered rapidly, so under 10 minutes, ideally less than 5, but the reality is that the nurses will most likely give a fluid bolus using the infusion pump, so you'll have to settle for 10 minutes. You're assessing for a response, so you're looking at a change in your value of your stroke volume, or you're looking for a change in your value of cardiac output. If you don't have cardiac output monitoring or even an art line, you're looking for things like a reduction in respiratory rate, or an increase in blood pressure, or an increase in urine output. Think not just about what you're going to do on the ITU, but think what you could do if you're reviewing a patient on a ward. How would you assess a positive response to your fluid challenge? And then, having ascertained that the patient has responded positively to a fluid challenge, you can repeat it as required. And obviously, if a patient has not responded to fluid, you need to make a judgment as to whether it is because you've not given enough fluid for the response to be obvious, or whether the patient is actually euvolemic, is not dehydrated or not hypovolemic, and you need to think about what else could be causing an insufficient blood pressure. Let's briefly chat about how you can assess whether a patient has responded positively to fluid or not. If you're using cardiac output monitoring, the stroke volume will increase. A stroke volume increase by greater than 10% is a positive response to a fluid challenge. If the stroke volume has not increased by over 10%, then that patient has not positively responded to the fluid challenge. If you think back to the Frank-Starling curve, what you're doing when you're giving fluid is you're moving somebody from the left side of that graph towards the right. So you should see a good stroke volume increase if you have increased your left ventricular end diastolic volume. More basically, the blood pressure should increase. If a patient is hypovolemic, and that was the cause of their low mean arterial pressure, if you've given them a fluid challenge, then that theoretically should increase their MAP. Urine output might increase. You might be giving fluid to patients because their urine output's low, and you may subsequently see a urine output increase over the next hour. Patients might display a fall in respiratory rate or a fall in their heart rate if they've been compensating for hypovolemia, an increase in respiratory rates and heart rates. To do that, you might see those measurables fall in response to your fluid challenge, and that would indicate that that patient needed that fluid and would be another indication to repeat another fluid challenge. And finally, you could see an improvement in arterial blood gases, either a fall in lactate or an improvement in pH, and that could indicate that you have identified the correct cause for peripheral oxygen deficiency and that your therapy has been the right choice. Now, having talked about how we would optimize heart rate and how we would optimize stroke volume using a fluid challenge, we'll go on to talk about vasoactive drugs. These are drugs that act on the cardiovascular system, either on the heart itself, improving the pump function, or on the vasculature to help improve and optimize systemic vascular resistance. As there are broadly two types of vasoactive drugs, inotropes and vasopressors, and they kind of split into those two categories. But in the reality, there is considerable crossover between them. Some inotropes will improve cardiac contractility. In other words, they'll help improve the quality, the force of your contraction, and thus improve your stroke volume. Some inotropes have positive chronotropic effects, and they'll increase heart rate too. And then vasopressors improve vascular tone. In other words, they squeeze the system and help maintain that pressure differential between the arterial system and the capillaries, and help forward flow of blood. Some vasopressors will also have an action on the myocardium and will improve your stroke volume. They may also improve stroke volume through improving venous return, getting more blood back to the right side of the heart. If you imagine as they improve flow through the system, you get better return to the right side of the heart, and then you'll get a subsequent increase in left ventricular output as well. And drug selection and dose depends on the clinical effect required, and also it depends on what the underlying cause is in many respects of the cardiovascular insufficiency. An example I'll give you is first-line vasopressor in sepsis would be noradrenaline, because that's what the surviving sepsis guidelines recommend. This slide's quite important. This shows you the site of action of the inotropic agents that we use on the ITU. We'll go through those now. But effectively, the principal driving action of the inotropes is to try and increase calcium-mediated muscular contraction. Okay, so the beta-adrenergic agents, for example, dobutamine or adrenaline, they'll act on the cell beta receptor in order to try and increase the amount of ATP available to generate more cyclic AMP. The cyclic AMP then opens the the L-type calcium channels to bring in calcium from outside of the cell back into the cell itself. That calcium coming from outside of the cell into the cell then helps stimulate via rhyolitidine receptors the calcium release within the sarcoplasmic reticulum, calcium-mediated calcium release. The calcium within the sarcoplasmic reticulum then binds to the troponin tropomyosin complex and facilitates actin and myosin contraction and cardiac muscle contraction. So the calcium coming from outside the cell doesn't cause the contraction. The calcium coming from outside the cell through the L-type channels stimulates extra calcium release within the sarcoplasmic reticulum, and it's that calcium that improves actin myosin contraction and cardiac muscle contraction. Okay, so beta agonists stimulate the beta receptors and generate more ATP that way. Phosphodiesterase inhibitors like milrinone prevent the breakdown of cyclic AMP, okay, by inhibiting the phosphodiesterase that breaks it down. And if there's more cyclic AMP around, then there's prolonged action of the L-type calcium channels and more calcium influx, which again stimulates sarcoplasmic reticulum calcium release. And then drugs such as calcium sensitizers such as levosimendan, they actually act at the level of the sarcoplasmic reticulum to make the troponin tropomyosin complex more sensitive to the calcium within the sarcoplasmic reticulum. So you get greater contraction for the same amount of calcium within the sarcoplasmic reticulum. That is very important because the drugs that act at the beta receptor and the phosphodiesterase inhibitors, they increase myocardial oxygen requirement. Okay, both of those involve more ATP being generated, more ATP being burned up. They increase the cardiac muscle oxygen requirement. The calcium sensitizers like levosimendan, they do not do that. They do not require the cell to have more oxygen. They just make it more sensitive to the calcium that's already within the system. So effectively, you've got free extra contraction. And that can be very important if you've got borderline myocardial oxygen supply, for example, in ischemic hearts or post-op hearts. Digoxin does have an inotropic action as well. It acts on the sodium-potassium ATPase, and that effectively, through downstream actions, it can help increase the calcium concentration gradient across the cell, causing more calcium influx through the L-type channels. And again, that has actions that stimulate myocardial activity, as I went through earlier. The next few slides are quite wordy. I'm not going to talk through them individually. What I'm going to do is I'm going to slowly skip through them, giving a few seconds for each slide. And then you can come back and go through these, pause on each of these slides yourself and have a read through. The information on these slides isn't enough for you to pass your anaesthetic or ITU exams, but it does give you a little bit of information about each drug that we use on the ITU, just to give you a kind of a basic knowledge of which ones we use and why we use them. For those of you doing anaesthetic or ITU exams, you will need to get a exam revision book or a pharmacology textbook, and that will go through these drugs individually and give you proper information about their mechanism of action, their side effects, their doses, how their pharmacokinetics and pharmacodynamics work as well. All of these drugs are very important within anaesthetic and intensive care practice, some more than others. Obviously, the main ones we use are noradrenaline, adrenaline, and then metaraminol or phenylephrine in theatre. So I suggest that you get a good working knowledge of each of these agents. You're going to be prescribing them, particularly in the ITU, quite a lot. This slide here is lifted from our infusions sheet that we keep in the patient notes on the ITU. It goes through the main inotropes, groups them all as inotropes, but it goes through the main drugs that we use on the unit and how you would prescribe them in the drug chart. So as you can see, noradrenaline's got 3 different concentrations, but single, double, and quad strength. But that is essentially how you write them up as infusions. And the typical dose regimes that we use, you can see the noradrenaline is 0.1 to 1 mics per kilo per minute. Adrenaline is pretty much the same, and you can go up to 2 mics per kilo per minute if you're desperate. Dobutamine, dopexamine, and dopamine are different to noradrenaline, but they're all broadly the same. Vasopressin is different to some of the others. You'll see that it's units per minute, 0.01 to 0.04 units per minute, as opposed to mics per kilo per minute. Levosimendan has a separate levosimendan policy that you'll have to go and find when you're going to prescribe levosimendan. And milrinone is a bit different to the rest as well. Generally speaking, if you're prescribing milrinone or levosimendan, you're going to be doing it under consultant direction, pretty much. The other drugs, noradrenaline, vasopressin, less so, and particularly those more senior among you will be used to prescribing those drugs for the correct indications. Having said that, if you are starting a patient on inotropes for the first time, particularly out of hours, it is prudent to ring us and let us know that that patient has deteriorated to the point where they need vasopressors. That's unless we have given you instructions on the evening ward round to start the NORAD if that patient gets hypotensive. Okay, use your judgment. As I said, go back through those last slides at your leisure and just have a read through the information there. But you will need to do more reading around the subject in order to gain greater depth of knowledge for your examinations. To summarise this very brief presentation on haemodynamics, it's just basically tried to give you the basic fundamentals as to how we assess and monitor and optimize the cardiovascular system on the ITU. Cardiovascular assessment requires building a picture from history and examination and additional data. The only difference really on the ITU is we've got more machines that can give us more additional data. We've glossed over in this talk how LIDCO works and how we interpret the values and so forth. You will get more teaching on this when you're with us on the unit. We will do bedside teaching and further teaching sessions that will go further into this and how we would interpret the various results in certain clinical situations. Likewise, we're using echocardiography. You'll all get an opportunity to get your hands on an echo probe, and for those of you with an interest in echocardiography, there'll be plenty of opportunity when you're here on the unit to try and get some basic experience and maybe start your first steps into echocardiography training. And those of you that have already got some qualifications behind you, for example, FICE or QSIC, then by all means feel free to crack on and practice, and there are lots of people around the unit who will be able to advise you and to help you develop your practice. This presentation has hopefully given you an idea as to how to target management appropriately to address abnormalities or deficiencies within the system. It's pretty basic stuff. Essentially, you're either going to be sorting out an abnormal heart rate or rhythm. You're probably going to be given some fluid to see if a patient is hypovolemic and will respond positively to a fluid challenge. And if that all doesn't work, then basically we're going to be starting some type of inotrope or vasopressor to try and correct what we can't correct in other more simple means. Vasoactive drugs affect different areas of the system. The information on the slides will give you a bit of an inkling as to what does what. Choose your drug with an effect in mind, rather than just picking the one, oh, I'll do that because I always do that. Pick the drug with the effect that you want in mind, and recognize that different drugs, and sometimes the same drug but at different doses, will have different effects on the cardiovascular system, whether that's a peripheral vasopressin effect or whether that's an effect on cardiac contractility. So target your treatment to the effect you want to achieve. And please don't forget to identify and treat the underlying cause. Patients develop cardiovascular or hemodynamic insufficiency for a reason. So it's not good enough to just treat the numbers. It's very easy in ITU to make the numbers look better without actually addressing what the fundamental problem is with that patient. Patients who are hypotensive, who have cardiac failure, generally it's happening for a reason. So don't forget the pathology behind the abnormal physiology. Identify what it is and try and treat it. The vast majority of the time it's going to be something simple. It's going to be something like sepsis. It's going to be something like ischemia or arrhythmia. Identify the underlying cause and treat that as well as optimizing the patient. I like to finish with an inspirational quote. While you're with us, you'll have plenty of opportunity to develop your kind of clinical and interpersonal skills. And if your actions create a legacy that inspire others to dream more, to learn more, do more and become more, then you're an excellent leader. And an excellent leader can be a clinical leader, or it can be a general in the army, it can be a great hospital manager, or it can be just that trainee that takes a bit of responsibility on their own shoulders that day. Dolly Parton, what a legend. I hope you've enjoyed this talk. And you find more to inspire you during your time here on the ITU. And if that presentation hasn't put you to sleep, then I look forward to working with you during your time at Frimley. Cheers, take care. If there are any questions, either send me an email or just speak to me on the unit. And best of luck. Physical signs of hypovolemia and dehydration. A patient sitting there with a bone-dry mouth and dry mucous membranes telling you they're gasping for a drink. That's a pretty good sign, but we look for things like skin turgor, delayed capillary refill time, collapsing IVCs and things like that. Look at deranged arterial blood gases, not just arterial blood gases, but an arterial venous differential in oxygen can give you an indication that patients are dry. You can use the echocardiography to have a look at the IVC diameter and see if it's collapsing or distending or not. We can look at the arterial line trace and see if you can see a big swing on that trace in a ventilated patient. I'll show you that on the next screen. And we can use cardiac output monitoring to show a stroke volume variation or a pulse pressure variation. If a stroke volume variation is greater than 10% or a pulse pressure variation is greater than 15%, that could give us an indication that that patient is on the dry side and would respond positively to a fluid bolus. Finally, you can do a straight leg raise on a patient. This is essentially where you lie the patient flat and then you elevate their legs in straight fashion to about 45 degrees, and you see if that causes an improvement in their blood pressure or their cardiac output or their stroke volume. And if they show a positive response to a straight leg raise, that indicates that patient is hypovolemic and would benefit from a fluid challenge.